Hello and welcome to the channel. If you're watching this video, I'm going to assume you're interested in dermatology or evidence-based medicine, preferably both, because today I'm going to be looking at this paper recently published in Lancet Oncology. It's a meta-analysis on the survival benefit from sentinel node biopsy in melanoma. For those of you who don't have a medical background or have a medical background outside of dermatology or surgery, I'll set the stage for what we're talking about. Melanoma is an important and serious skin cancer, which causes significant morbidity and mortality, particularly in countries like Australia. Sentinel node biopsy is a surgical procedure where the lymph node draining the area of skin where the melanoma occurs is identified and tested to see if it has melanoma, which would mean a metastasis. And if it does, that would suggest different therapeutic or prognostic implications for the patient. This procedure has had a lot of controversy over the years, and the medical literature has lots of articles from supporters and critics battling out their opinions in the literature. The purpose of this presentation is not to relitigate all the papers and controversies of the past. I'm just going to have a closer look at this paper. It's my opinion on the paper. Let's get into it. When we talk about the methodology of this study, it's a systematic review and meta-analysis of previous research. The aim of the study is to establish whether there is a reduction in the risk of death from melanoma after sentinel node biopsy. This is a screenshot of the abstract. In practice, for many doctors, the abstract is the start and end of reading a paper. It's the summary, right? And when you see these details and numbers, 13 studies in the meta-analysis with 40,000 patients, a highly statistically significant result showing a reduced hazard ratio in favor of sentinel node biopsy, and a low heterogeneity of included studies in the meta-analysis, not to mention it's published in a reputable journal like Lancet Oncology, well, that would be game, set, and match, wouldn't it? Here are the results in more detail. This diagram is called a forest plot. It's a way of representing the results of a meta-analysis. On the left here are the 13 studies that were included in the meta-analysis. And here are the hazard ratios of each study on the right. And here at the bottom, this diamond shape represents the summary after mathematically combining these 13 studies. When it lies to the left, it means the hazard ratio is less than 1. 1 being the null hypothesis that there is no difference between the groups. So less than 1 means there is a survival benefit from the procedure. The nice thing about forest plots is that just with the eyeball test, you can see that many of these studies were already trending on the left side of the line. So it's not surprising when you combine them that the final result would also be on the left side of the line. So what's the conclusion of the paper? That people with melanoma who have a sentinel node biopsy have a reduced risk of dying from melanoma. But if you know anything about evidence-based medicine, you know the devil's in the detail. Unfortunately, examining the detail means reading and scrutinizing the whole paper, which many doctors don't do, because they are pressed for time or lack the necessary confidence. That's understandable, right? The problem is, I'm not sure even journal reviewers do it. So I'll do it for you and them. Before I talk specifics about this paper, I need to digress for the benefit of those of you less familiar with study types. What's a meta-analysis? A meta-analysis is an attempt to combine the best available research on a topic, hoping to get a better answer. To do that, every meta-analysis starts with a systematic review. A systematic review has two components, which is largely explained in its name. The systematic component is to find all relevant research on the topic. That means a thorough literature search. Once you find all the research, you formally review each paper for suitability and quality. That's a critical step because if you combine bad quality research with your good ones, it messes with your final output. More on this later. Finally, when you found all the good quality research, you can do the last step of mathematically combining the results. That's the meta-analysis. Combining the results of all the studies you found, and if you have good quality ingredients, you get a Michelin star dish. Now, for the rest of this talk, I'm going to reference the Cochrane Group's Guide on Systematic Reviews and Meta-Analysis, which is a detailed document that provides scientific guidance on how to do these things. It's a guide written by experts on producing such reviews. And I know the authors won't object to this reference as an authority because they used it themselves. It's right there as reference 12 in their paper. With that background in mind, we can dive into the nitty-gritty of this paper. The authors start with a comprehensive literature search and all seems good there. They assess the papers using standard tools, Cochrane risk of bias tool for randomized trials, and the Newcastle-Ottawa scale for non-randomized studies. Nothing wrong with these choices, they are commonly used. After reviewing the papers, they decide that 13 studies fulfill what they are looking for in measuring survival after sentinel node biopsy and do the meta-analysis on these 13 studies. That is, these 13 studies have compared patients who had sentinel node biopsy with those that did not. And they are going to pull the results of each individual study into the meta-analysis. Here's the first thing you notice. Of the 13 studies, only one is a randomized trial, which you may have heard is generally the gold standard for assessing interventions in medicine. The other 12 studies, they were observational studies, retrospective, using historical controls, perhaps matched but not randomized. Now, you may also have heard that observational studies are good for measuring association, but are weak at looking at causation because they tend to be plagued by confounders, even when you try all kinds of tricks like propensity match scores, because it is the unknown confounders that will lead the results astray. You can only match for things you know, but it's the unknown confounders that cause problems with observational research. That's why randomized trials are superior in this regard. Randomization controls for both known and unknown confounders. Of 13 studies, we are not talking 12 randomized trials and one observational study, where you might argue the lone observational study only contributed a little to the final result. We are talking 12 out of 13 studies of this meta-analysis coming from observational data, and the authors will use the final combined result to make a causative statement. Anyway, of these 12 observational studies, you might think they must have been really high quality observational studies to make it into the meta-analysis, free of significant bias, because you wouldn't want highly biased papers in your meta-analysis, right? And it seems that way when you look at this table. The authors state that in their assessment, the risk of bias was not serious and plausible confounding was not present. Plausible confounding, not present. Okay, sounds good so far. You might still be uncomfortable because observational studies are prone to confounding errors, but what can you do? Without reading the 13 papers, you've got to accept the author's judgment. After all, they've read and assessed all the papers using the formal Newcastle-Ottawa scale. If only you could see the formal assessments made by the authors. That'd be more reassuring, wouldn't it? Lo and behold, buried in the supplementary tables are the formal risk of bias assessments done by the authors themselves. For those of you less experienced in reading medical papers, the supplementary section of a study is where good data goes to die. It's the place where, realistically speaking, no editor or reviewer, and certainly not the average reader, would ever go look. The first thing you notice is that about half of the 12 observational studies were judged by the authors themselves to be at high risk of bias. And they are at high risk of bias in some of the most important areas of a study. Firstly, the patients were not representative of the patients you normally see with melanoma and are not representative of those that might undergo a sentinel node biopsy. Patients and procedures not representative of what you normally see or do, but we want to add them all together and make causative statements. Secondly, the treatment groups are not similar to one another. This is really damning in comparative studies. That's to say, those that did and did not have sentinel node biopsy were different to each other in some other manner apart from having the node biopsy, which means there may be reasons other than sentinel node biopsy that explain their results. By definition, that's textbook confounding and judged to be at high risk from the authors themselves. What? I thought the authors said that plausible confounding was not present. Seems to be when treatment groups are not similar in over half the included studies, that confounding is much more than just plausible, it's certain. To illustrate the kind of bias we're talking about, here is one of the 12 observational studies whose results were added into the pot of the meta-analysis. Here you can see a big discrepancy between the groups that had and did not have sentinel node biopsy. In a third of the group that did not have node biopsy, the baseline severity of their melanoma, the thickness of the tumor, was unknown, as opposed to only 6% in the biopsy group, 35% versus 6%. Something about these two groups is very different. Perhaps in the group that did not have the biopsy, the tumors were thicker. Perhaps the kind of care they received was suboptimal. For the purposes of this discussion, it doesn't really matter how or why they differ. The point is they are different, meaning that significant confounding and therefore bias was present. If we want proof that confounding in this study's result was present, we just have to look at the survival curves of this study. I will point out this section where you see the two curves intersecting at multiple time points. Now, I know many of you will not be experts on survival analysis, so I would just say that when survival curves intersect, the proportional hazards assumption, which is a core assumption of survival analysis, no longer holds. And therefore, the log-rank test for significance, in this case calculated as less than 0.01, is no longer reliable. When survival curves intersect, significant confounding is present. What that confounding is might be interesting to study, but again, for the purposes of this discussion, why they intersect and what the confounders are is not relevant. The point is that they are there and are causing significant bias that is obvious just by looking at the survival curves. Anyone not convinced about these claims on survival analysis can Google or ChatGPT it. Significant confounding and bias was present in the results of this study, and yet it was one of the ones added into the meta-analysis to give the combined results and conclusions. And the authors judged about half of the 12 included studies to be at high risk of bias. Remember the forest plot I showed you earlier where many studies fell to the left of the null hypothesis line? That's because many of them are biased, as judged by the authors themselves, and were in favor of sentinel node biopsy, like this one. So when you add them all together, were you ever going to get any other result? Right? Some of you might be thinking about that very impressive abstract at the start of this presentation about the large study numbers, 40,000 patients. Surely the size of the study helps compensate for any biases that might be present. My response would be to remind you of the difference between precision and accuracy in science. When we measure things in science, whether it's the weight of an object or death from melanoma, we have two types of errors: random error and systematic error. The level of precision in measurements is determined by the amount of random error, and random error is reduced with large sample sizes. But the level of accuracy is determined by systematic errors. And systematic errors, which in medicine we call bias, can only be addressed by study design, not sample size. No matter how large your study, if it is biased, you will not overcome systematic error. You will only be precisely wrong. So ignore the 40,000 patients in this study. It cannot overcome the problems we're talking about. What about the low heterogeneity? You've seen I-squared as a test statistic presented all the time in meta-analysis. You might have heard it means the meta-analysis is good or reliable or believable. It keeps getting emphasized in this paper, almost as if that's some kind of insurance about how reliable these results are. Not at all. After p-values, the I-squared test statistic must be the most abused and misunderstood statistic in the medical literature. I'm going to quote this statistician here. The primary index employed to report heterogeneity is the I-squared statistic. While the use of the I-squared for this purpose is ubiquitous, it is nevertheless a serious mistake based on a fundamental misunderstanding of this index. The I-squared statistic does not tell us how much the effect size varies. End quote. Not only does the I-squared test not mean what we think it means, but for the same reason as sample size, it cannot overcome systematic errors or bias. You see this target here? All these shots are precise and consistent, but they are still off target and wrong. Being precise and consistent does not mean that you are hitting the right answer. You're just hitting the wrong answer again and again, consistently. If all the bias studies are pointing in the same but wrong direction, then they will be in agreement with one another and there will be low heterogeneity. But they are still wrong. It's just that they agree well with one another. Here, I want to emphasize the really important bit I alluded to earlier. And I'm just going to quote the Cochrane Handbook again. Since the conclusions drawn in a review depend on the results of the included studies, if these results are biased, then a meta-analysis of the studies will produce a misleading conclusion. And it is not appropriate to present analyses and interpretations while ignoring flaws identified during the assessment of risk of bias. End quote. This is best summarized by the adage garbage in, garbage out, which I think is self-explanatory and intuitive. If you put flawed science into a pot, you cannot expect, no matter how much you stir, or in this case, do fancy statistics, that the output will be any good. Let's look at what was said in the paper. Quote, of the 60 studies reporting survival for people with melanoma undergoing sentinel node biopsy, 13 considered other prognostic features in their analysis, had limited selection bias, and were meta-analyzed. End quote. Limited selection bias after what the authors themselves judged and presented in the supplementary table. Let's look at this statement. The robustness of the meta-analysis of risk of death from melanoma was demonstrated by the consistency of results on sensitivity analysis and gives much greater confidence in the reliability of results. End quote. There is a confusion here between the role of consistency and accuracy in a study. This paper performs sensitivity analyses by removing one paper at a time and seeing how it would have affected results. When 12 out of 13 studies are observational and more than half are seriously biased, removing one at a time in a sensitivity analysis is not meaningful. Let me summarize. Significant bias existed in many of the included studies of this meta-analysis, which the authors judged themselves when reviewing each paper they added into the meta-analysis. The massive sample size, the fancy I-squared test statistics for heterogeneity do not overcome or compensate for systematic errors. When all the studies you put in a pot are biased, especially in the same direction, the final product will be biased. It can't be any other way. In my opinion, this conclusion that sentinel node biopsy results in less death from melanoma, it's not reasonable based on how this study was conducted. That's not the same as saying some future study might not prove it. I'm just saying that it's not a reasonable conclusion to draw from a study like this one. For those of you who are experienced at EBM, what I've shown probably comes as no surprise. For those of you who are less familiar with these issues, I think papers like these raise even more important questions. Like, how does this stuff get past editors and reviewers? What responsibility do journals have to properly scrutinize paper before accepting them for publication? What happens when doctors who might not read a whole paper, who might not have critical appraisal skills, what happens when they use this evidence to treat patients? Thank you for your time. I hope you got something out of the video. If you've enjoyed it, please click the like button. If you'd like to see more videos like this, subscribe to the channel. I hope to add more videos over time because this is literally the first one. If you have feedback or criticism of what I've presented, add your comments. I'm happy to take on board your criticism. Thank you again.